Sorry, I'll quickly unmute. So thank you, Rafi, for the opportunity to moderate a really interesting panel for us on the SJIA diagnostic and classification criteria. And there are lots of, I'm Peter Nigrovic from Boston Children's. There are lots of people in this room who would be excellent panelists for this. We picked 4 as we thought about this. Yuki, Fabrizio, and Dan, I think known to most of you as really international experts in this area. So the challenge we have is, as was outlined really beautifully by Rashmi and by Alexi, is that it's difficult to classify these patients. And that makes doing clinical trials where maintaining a clear, defined population important, makes that quite difficult. And so there's an abundance of choice in terms of criteria. And this is not all of them, but we've listed here 4 different criteria sets. And since the details are somewhat important, I'll go over them in just a little bit of detail. So the ones we want to highlight are the classic ones, which are the ILAR ones, or International Leagues of Association for Rheumatology. This is the standard one that we've dealt with for quite a long time, since they were published in 2004. Under Yuki's leadership, Kara devised a different set that was somewhat more inclusive. There's an even older set in terms of publication date for adult onset Still's disease. And then more recently, Printo came up with another revised set of preliminary criteria. And so these differ in areas where I've highlighted in red. So these 2 sets, the ILAR criteria, require arthritis as part of the diagnosis. That is, these diseases are subsets of juvenile idiopathic arthritis where you have to have arthritis to qualify. The age of onset differs a little bit, 16 or 19, and the duration of fevers differs a little bit. But otherwise, the presentation is pretty classic. Adult onset Still's disease, as Rashmi mentioned, does not require arthritis. It operates a little bit like the Jones criteria in rheumatic fever. It has major and minor criteria. You have to have at least 2 criteria in major category and at least 5 overall. And it includes fever for only 1 week, and arthralgias is one of the major criteria. You don't have to have actual swelling. Sore throat is something that's a hallmark of adult onset Still's disease. We don't often think about it too much in the pediatric group, but it's one of the minor criteria here. I do want to call out that this initial study included 11 patients that had similar episodes in childhood. So we might actually say that some of the patients enrolled in this original descriptive series were already Still's disease, or the systemic JA version. And finally, Printo has come up with what I think is a very nice set of criteria defining onset as before the 18th birthday, but then again, a major and minor criteria set where arthritis is possible as a criterion, but not necessary. So these criteria highlight 2 key sort of break points or decision points in the Still's definition. The first is age of onset, and that's our systemic J and adult onset Still's disease different. And the second is arthritis. Is arthritis required? So I'll handle the first of these, and we'll have Bas handle the second, and then we'll go to just looking at we'll hear from some data from Fabrizio as well, and some thoughts from Dan as we think about these questions. So just to look at the epidemiology of the condition we're dealing with, this is a summary of 1,000 patients from published series of age of onset. It was the number of patients on the y-axis and the year of life from 0 to 50, first year of life, so 0 to 1 to 15 to 16 in the x-axis. And it shows you that this is predominantly early onset child disease, so from infancy to 5 or 6 is the peak, but it doesn't end there. There's no suggestion that it stops around this time. And in fact, the idea that we should cut off anything at 16 is sort of a historically sort of challenging idea. And as far as I can tell, comes really from a single early important paper in the field where we looked at juvenile arthritis, where the leaders in the field, Barbara Ansel and Eric Bywaters, arbitrarily picked a cutoff for their first series, which they used as 16. Which, as I understand it, had to do with nursing requirements for children as opposed to adults. And they used this cutoff of under 15 as the definition for what counted as childhood arthritis. And this has then perpetuated since then. But it wasn't biological. And in fact, both Barbara Ensel and Eric Bywaters have gone on to say in their subsequent work that this cutoff point was entirely arbitrary. So there's never been any biology behind 16. There isn't any biology behind 16. We should recognize that. That's particularly true when we think about the Stills phenotype, where Eric Bywaters, when he first described it, explicitly says that this paper goes on to show that Stills disease syndrome occurs in adults. That is the point was to say that it's the same syndrome. Now, is that true? One can say it and believe it, but are there data to say that they're actually the same syndrome across age? And I think we've heard a lot about IL-18 as an important marker. Here's some work from Scott Canna's group showing how IL-18 levels are very high in systemic J, particularly in MAS. And that characteristic is shared by adult onset Stills disease compared to, say, another inflammatory adult arthritis, rheumatoid arthritis. This observation that the biology looks the same extends also to ferritin, D-dimer, interleukin-1, interleukin-6, interferon gamma, S100 proteins, NK cell dysfunction. You can go on and on. The biology looks like it's continuous. So now, continuous does not mean absolutely identical. It doesn't have to be. We know that in every disease phenotype, rheumatoid arthritis, lupus, there's a broad phenotype among patients. If you look at the arthritis course in systemic J, these are historical series from dates before we really had good biologic interventions. The percentage of patients that goes on to a persistent chronic arthritis course is inevitably around 50% or more. So that's what we expect from the pediatric series. Adult series are a little different. So these are adult onset arthritis series where the persistent arthritis phenotype, and I'll call out this row here, is sort of around 30 to 40%. So maybe there's subtle differences. Sore throat is reported in the adult series. We don't really report it in the pediatric series. That's probably because the kids are too young to tell us. But it's present, it's commonly. But then fever, rash, arthritis. I'd highlight here, arthritis is not uniform because of the definitions. So it's not between 80 and 90%, 95% in the adult series. But clinically, it looks broadly the same. Now, as was highlighted, systemic J is also unlikely to be one syndrome. So we've seen this with IL-6 and IL-18 profiling, that there seem to be subgroups that differentiate by risk of arthritis and risk of MAS. So we shouldn't be expecting that the syndrome should be identical. That's not the definitional criteria of what a good criteria set captures. And even in pediatric arthritis, even in systemic J, there's a difference based on age of onset. So this is a series from Dr. Russo in South America showing that the children who started in this very early window, less than 18 months, have a different kind of arthritis course with more organomegaly, more serositis, more growth impairment, more MAS. So what I would say here is that variation within systemic J is likely greater than between systemic J and Stills disease or adult onset Stills. Arguing the point that these really should be considered together. Now, I'll turn this over to Vas to look at the question of whether all systemic J patients have to have arthritis. And I'd emphasize looking at the historical series that historically hadn't been true until the criteria changed, right? So this is a data set from South America using the ILR criteria, and 100% of those patients had arthritis because they had to get into the series. But if you look at the older series where that was not required, the numbers were much more like the adult onset Stills disease, 80 to 80%. And we can talk about the CARE data at some point later on if we wish. So I'll turn it over here to Vas, and if you don't mind, Vas, taking over, and I will advance the data, the slides for you.
Thank you very much, Peter. Very good morning for you. It's afternoon here in Europe. I hope I can be clearly heard because I experienced some speaker problems. Is it okay?
Got it.
Okay, thank you. So I'd like to contribute to this discussion by adding some of our Dutch data. Since 12 years, 30 now, 2009, we are prospectively collecting and sampling systemic JIA patients, first in Utrecht, one of the bigger cities here, the 6 academic hospitals, but later on in a national cohort setting since 2017. And we have been following up these patients very carefully and also treating them all with a standardized treatment flow chart actually in the first year, starting anakinra, so IL-1 blockade as first-line treatment. And in the course of our cohort study, we experienced, we came across patients that, in our opinion, were typically systemic JIA patients, but they did not display overt arthritis. And the first patients we really did a lot of additional investigations, including a full genetic screen. Most of them received a PET-CT scan and also a bone marrow punction to exclude malignancies. But more and more we were able to identify and recognize these patients, also because of the fact that we were able to have on spot actually daily measurements of potential biomarkers like IL-18. And this is a publication of the first 42 patients of the Dutch cohort, of whom 30 were fulfilling the ILA criteria. It's the second column. So systemic JIA with onset, with arthritis at onset of disease. But we also listed here 12 patients who did not have arthritis at that time, and also not at time of start of therapy. In the follow-up of these patients, 5 of these patients developed arthritis in the later phase of the disease. So it's not that these patients cannot get arthritis, but at least at onset they did not suffer from arthritis. And except for arthritis, they were very, very similar. If you look at clinical characteristics like age of start or rash or hepatosplenomegaly, it's very similar. And also if you look at laboratory assessments, there are actually no significant differences between the two groups, either with or without arthritis. Can I get the following slide? Next slide. This is a bit better displayed. Here you see in the lower row also potential biomarkers like IL-18, which were not significantly different between the two groups. And also, for example, soluble IL-2 receptor, it's also CD25, is not significantly different between the two groups. Next slide. As I said, in the Netherlands, we have a standardized treatment plan since 2009. In which we start with anakinra's first-line treatment without the addition of steroids, and we only add corticosteroids if there's no complete response in the next week or next months. And in patients that get into clinical inactive disease, we try to taper and stop the anakinra as well after 3 months. So here you can see that the response at 2-3 months, which is all on anakinra, is actually pretty good. It's about 3/4 of the patients are in complete clinical response. And at 12 months here, slightly more than half of these patients have been able to taper and stop anakinra. So this is a clinical remission of medication. You can see that for those two cohorts, either with or without arthritis at onset, there's not much, no significant difference, although the numbers, of course, are pretty small. So this means that there's a similar response, or if you want, non-response, to anakinra as first-line treatment for systemic JIA patients fulfilling ILA criteria or present without arthritis at onset. So it was published in 2019. Can I get the next slide, Peter? And here you can see follow-up data very recently added up to 66 patients now, also from other centers in the Netherlands. You can see in the left panel that IL-18 levels of the 22 patients without arthritis at onset, it did include the 12 in Utrecht, but also from other centers now, are not significantly different than the 46 patients fulfilling the ILA criteria. And again, similar, but now slightly different responses at 1 year. Here we displayed complete response, which will mean complete inactive disease either on or off anakinra at 1 year, and incomplete responses either active disease or necessity for moderate use or moderate doses of corticosteroids next to anakinra. I think this was my last slide for now, so I'm going to hand it over to
Dan, I think, right now. So thank you very much, Bas. Great data. So Dan?
So I wanted to show you how far we've gotten with a currently enrolling active trial with approval from both the European Medicines Authority and the FDA. So this trial is ongoing. When it first started, we used the classic ILAR criteria, but it's been amended over time. And the first thing that happened was that we eliminated the requirement in ILR that has to do with autoimmune diseases in first-degree relatives. And then the other criteria is that there be spiking fever for at least 1 day due to systemic JIA in the screening period and before the first dose. It still requires the presence of arthritis in at least 2 joints at screening and baseline, and they have to have elevated erythrocyte sedimentation rate as part of the protocol to include patients who have active disease. So the advances of the criteria in this most recent amendment to this clinical trial is that there's no requirement for 6 weeks of arthritis. We've gotten rid of the family history exclusion, which I think are irrelevant for systemic JIA. And it only requires 1 day of fever in the prior week, and arthritis is required, but we've gotten rid of the 6-week duration. The goal of this study is to get closer to what I think is the general agreement of a broader definition of systemic JIA. The only other comment I'd like to add is in relation to the Printo diagnostic criteria that Peter presented earlier in the meeting. Those criteria were developed by an international group of pediatric rheumatologists, and there was unanimous agreement that the age cutoff was arbitrary, and everyone wanted to move forward with an approach to combine adult and pediatric onset patients. But since there were no adult rheumatologists at the meeting, we felt like it was presumptuous of us to do that in the absence of Still's disease experts. So an integrated part of the process of moving from those preliminary criteria to final criteria will be to convene a meeting of us adult onset Still's disease experts and SJIA experts to come up with 1 or 2 criteria that will then be formally tested in groups of adult onset and pediatric onset patients for their measurement characteristics, with the goal of coming up with a single set of criteria that'll work for across the full age range. So that's an integrated part of the ongoing effort for the revision of the ILAR criteria for systemic JIA and Still's disease.
Thanks, Dan.
Peter.
So why don't we move on to some data about these criteria, and this will be presented by Fabrizio from Rome.
So just before getting to the data, we played around with some of our patients. The one we have seen from the onset of the disease, and their first admission was at our center, so we could really monitor what was happening. I want to follow up on what Dan was just saying. We have just presented to EULAR and press the proposal, a joint proposal from adult and pediatric rheumatologists. Unfortunately, it's only Europe, for the way this is organized and supported, to provide the first joint press EULAR recommendation on diagnosis and management of this disease. I'll call it this disease in children and adults. And I think this is, again, we are moving forward a bit slowly, I agree. Rashmi would like it to be faster, but we are moving forward. So what we did recently was actually to look at this the last 11 consecutive SJIA patient in which we made the diagnosis and treated as SJIA, as much as Bas is doing in his real-life empiric open-label trial, that had first admission at our center, looked at time, because I think the issue is not only presence of a given feature, but it's time of appearance. And I'm looking at Peter, window of opportunity that is exploited on or lost or missed. And we have used 5 sets of criteria: the ILAR, I would say, the rigid application of 6 weeks duration of arthritis and 2 weeks of fever. And you know, all of you know what I'm talking about. What we call ILAR modified, that is pretty close to what Dan has described right now in the amendment of the ongoing clinical trials, which is arthritis at physical examination, no limit on disease, on arthritis duration. So 1 day should have been sufficient. Printer provisional criteria and the CARA operational definition of new cases were the Yamaguchi. The next slide, please, Peter. And this is median time of appearance of signs and symptoms that are included in all these sets of criteria. And you see the median time and the range. And the range for some of them is not that wide. You can see that. For some of them is actually pretty wide. And obviously arthritis is at the very bottom of your right. Thank you very much. Next slide, please, Peter. So this is the percent of patient meeting our criteria, no surprise. ILAR original, ILAR modified is that because we started treatment before the 6 weeks duration of arthritis, and obviously this patient did not meet the ILAR criteria because we didn't want to wait 6 weeks. That's pretty obvious, and the children was sick enough not to allow us to wait 6 weeks. And here you see the print of the CARA and the Yamaguchi criteria in these patients. The next slides show you the time. Thank you, Peter. Show you the time, median time from, apologies for the typo, from disease onset to meeting the criteria, days. And again, it's a time issue. You want these criteria to be met really in a matter of a few days or a few weeks, because you want to treat the patient early, because you want to make them feel better, and because you want them to use the window of opportunity, which we all believe is there. And I think this is my last slide. Thank you very much, Peter.
Okay, so I think at this point we're ready to open it up for discussion. So again, we have these 4 criteria sets that we looked at, the ILAR, the modified ILARs, either the CARA modification or the modification that Fabrizio was just talking about, where there's the only limitation is changing the duration of arthritis to 1 day. The Stills criteria for Yamaguchi, and then Printo. Which I think it's important to emphasize Dan's point that this was really quite arbitrary and intentionally so, and the goal will be expanded out more broadly. So the questions I think we thought we should address, and this is for the panelists to start, and then certainly there's opportunities in the chat to discuss these questions. I defer to Rashmi on this. But so what are the best criteria for studies of Stills? And I think we should be thinking both in terms of new onset disease, so what we call incident disease, or prevalent disease, which is established. Diseases have been around for a while, and you can imagine the criteria sets could be different for these. So what are the potential pitfalls of looser entry criteria? So what could we get wrong? How do we harm patients? How do we mess up studies if we use a shorter duration of fever, for example, or different characteristics of fever, or arthritis and no arthritis? Thinking about how do we do trials now in patients who don't have arthritis? How do we do studies that enroll both children and adults, recognizing that the differential diagnosis of fever of unknown origin, FUO, is different, where adults are much more likely to have, for example, different kinds of cancers or other acquired syndromes, including newly defined ones such as VEXAS. And then how do we work with regulators from the FDA and EMA to do such studies? And I think we have regulators here. I would love to hear from them as well. So at that point, I will stop sharing. I would love to find a way to see the panelists while still looking at the questions. I guess maybe I should just stay like this. Maybe I will start with inviting Yuki to comment, because Yuki has been involved in some of the key trials and the criteria development. And if I can catch you off guard, Yuki, and have you start with your reflections on some of these questions.
Well, I think we can all agree that if we can come up with a biological definition for this disease, that would certainly solve a lot of issues for us. And I think we're getting close to that. However, I think it is really important to make sure that we separate the issues surrounding incident or new onset cases and the diagnostic issues surrounding those patients versus patients with established disease who may have never developed criteria, especially such as arthritis. I think that in the incident or new onset patients, you're really still uncertain about, the diagnosis. So I think that is one of the major reasons, for example, in the CARA criteria, where we continue to, mandate that the patients had to have arthritis, albeit for, a shorter period of time, for, I believe it was a week or 10 days. Because, I think that the consensus was that people felt that it was important that, there was a demonstration that this indeed was systemic JIA and not some other process. But that does pose difficulties using that criteria, or any criteria for that matter, that includes arthritis as a diagnostic criterion or an entry criteria for clinical trials. And I think, in fact, what happens in practice is that people do treat patients who the pediatric rheumatologist, really, thinks that if that patient has systemic JIA, they will treat that patient before developing some signs, including arthritis. And that has been evident in some of the studies that we've done. For example, the Frost study, which did require, this 1 week of arthritis. Many of the patients who did not enroll because they failed to meet that criterion, and the treating rheumatologist felt that, they had to treat these patients.
I think bears an important point that many of the patients that we're thinking about enrolling in, particularly, for example, the refractory SJIA trials, the duration of the disease is going to be very reassuring, versus new onset disease where you have fever for a week and you don't know what it is. There, I think there's a lot more uncertainty. Can I open that discussion further to the panelists? What other comments? Who would like to comment further on this question? So maybe I'll turn it to Bas, because Bas has the leading perspective series here. So Bas, you have, what kind of troubles have you run into in the diagnosis of new onset disease and the uncertainties related to new onset disease in your population? And have there been any mistakes? Have you run into any patients you thought had disease, you treated them as though they had disease, but ended up having something else? I've done that. So.
That's a good question, actually. So we, of course, we identified patients presenting like systemic JIA, but turning out to have another diagnosis, but we never started treatment with anakinra in the patient, at least not here in Utrecht. I would have to ask my colleagues in the other 5 academic centers whether, I think occasionally this, of course, may occur, but it is very rare.
So I find it less rare.
So I think that the risk
is so benign in terms of infectious risk, or if it's lymphoma or leukemia or an infection, and you start anakinra, nothing bad happens. So we often use anakinra sometimes early on as a diagnostic test. I don't know if other people are doing that, but we certainly are.
We certainly.
Certainly.
Oh yeah, sorry. Sorry, Bas, go ahead.
Oh, go ahead.
Fabrizio, dive in.
I was just jumping in on what Peter was saying, because there is a large prospective experience that Bas is accumulating, and we are doing the same. And we really try to use IL-1 inhibition with a fast-acting drug as anakinra and a fast-clearing drug as anakinra, almost as a diagnostic test. And it won't mask anything else. Now, this is an issue. This is clear for clinical practice for everyday life. In a clinical trial is a completely different issue, okay? And I'm sure that in real life and in a pragmatic approach to a clinical trial, we want to move as early as possible, but playing it safe in the setting of a clinical trial. I don't think we can accept, minimal disease duration of 6 months to get into a clinical trial, or, several months. This is not acceptable, no. And we have to find a way to do that. In real life, anakinra is very safe in this setting, and I see Vas nodding. In a clinical trial you have to have excluded a number of things. And I noticed a couple of comments in the chat pointing to exclusion. And I think this is a key point. Forgot who was saying something, but there was a comment on exclusion.
Could I ask Nikolay, I don't know if you are available to, I think you can speak. It looks like you're on the panel there, from the FDA, to give us any thoughts on these criteria or how we work with regulators. The last question.
Thanks for the opportunity. Do you hear me, by the way?
Yes.
Okay. First of all, thanks to Rashmi and the group for inviting me. I think this is an extremely valuable discussion for us too, and I would say educational, because I think you guys are the subject matter experts, and we certainly rely on your expertise and recommendations and advice and guidance of how to think about specific diseases, management of diseases, and so on. So I really want to thank you. So that's sort of an introduction from my end. Now, I think this discussion seems to be very informative in a sense that there are still ongoing discussions within the scientific community about how to define the disease. And I really want to get a better sense whether you consider all of these subtypes under the umbrella of systemic JIA, or do you think that they are just different disease entities? And then I will tell you about how I would think about these subsets.
My guess is you might get 50 different answers to that question in terms of their subtleties. But I think, can I get a show of hands who said that they're part of a general continuum? Do we say continuum is good, recognizing that there's subsets within continuum? I mean, we're going to find, we know, for example, with FAMIN1 as a gene, that there are subsets that we're going to be breaking out at time. And, the work from other groups, Mike Umbrello comes to mind, but others are going to pop out subsets, we hope, that are genetically determined. But broadly, to begin to start, we have to lump fork and split. So maybe if we leave it there for the moment, and then we'll ask you for your next point about how you would think then to proceed functionally.
I mean, I think this is certainly very helpful. And I think we're also viewing these as subsets of an umbrella disease, and how these subsets are defined for specific trials is driven partly by the objective of enriching for specific patients where you can actually assess efficacy in a reliable way. In other words, I'm not sure that FDA has required or would require that arthritis is included in the classification or the enrollment criteria, but that might be one way to enrich for patients where you can assess really the benefits in a smaller sample or smaller trial for a specific drug. And we have managed or viewed these trials as representative of the broader population, even though those studies may have enrolled primarily arthritis patients. So the products that we have approved for SJIA are for the broad population of SJIA, not necessarily, defining patients with arthritis or without arthritis, or patients with interstitial lung disease or some other manifestation. So I think we have been as open as possible to consider this as a spectrum of disease, and ultimately view the clinical trials as representative of trials in the broader population. And we clearly recognize that some of these treatments are not going to work for everyone. I'll pause here and see if you have any other thoughts or considerations or questions.
If I may ask a question of Nikolay.
Sure,
of course, as our boss, yes, Rashmi, you may ask a question.
Thank you. Thank you so much for being here. And I am so, I'm pushing all of you, so I apologize regarding that. But I mean, so I'll turn the question and what you're asking on its head. So what do we do with these groups? Yeah. We have these patients who do not respond to the drugs approved by the majority for the, let's say, the typical SJIA. But they get in the clinic, they get classified as SJIA, even though they don't fit the criteria. We have a contact registry where every patient has to say, were you diagnosed by a rheumatologist? And everybody says yes before they can fill out our contact registry. And 35% of them, who admittedly we are getting the refractory patients more, don't have arthritis. So what do we do? How do we do trials for these patients? Do we call it SJIA? Do we call it refractory SJIA? Do we call it a different disease name? I mean, we shouldn't wait for the medicines for us to know everything about the biology.
So I think from our perspective, as long as a clinical trial can define a patient population that an average clinician at the end of the day will be able to identify and treat with specific treatment, and that population has features that we can assess the burden of disease, I think that's a reasonable population to study. Now, again, I think there is a high unmet need in the overall population, even the traditional or more typical SJIA patients that still does not respond to the currently available therapies. So I think there is an unmet need for those patients too. And whether those should be specifically excluded from future trials or not, I think it would depend on how well this patient population is, how well defined this patient population is for the clinical trial. Now, if there are specific manifestations that could be targeted by specific treatments, these patients could be, defined and carved out of the broader population. Again, that would be a way of enriching patients or enriching the study for specific patients that could respond to specific treatments. And I'm not sure whether there are, again, specific subsets that might be responsive to one intervention versus another. I think it was very well pointed out in the chat that this is really a spectrum of disease that has heterogeneous manifestations, similar to lupus or other complex immune-mediated diseases where these are systemic diseases that may target different organs in different patients.
So I think these are good points. I see, I'm just looking briefly at the comments, and I see a comment from Laura Schemberg that we want to be careful about lumping because we may miss efficacy for subsets. So I think that's an important consideration here that's based on what Nikolay talks about of measurable efficacy markers that may be different in different groups. On the other hand, if you subset too small, you'll have one patient per study. So there has to be some balance between those two. Dan, Fabrizio, do you want to add comments on that as experienced trialists?
Well, I think when you set the criteria, I think the criteria should be inclusive so that all the patients that have this disease that has multiple manifestations are included in the umbrella of this disease, whatever we call it. And then when you come to design clinical trials, you need to pick the patients that are enrolled in a clinical trial based on the biology of the treatment that's going to be tested, so that there needs to be some biologic rationale for why this particular new treatment fits the patients who are going to be enrolled in the trial. So the biology here should drive the patients that are selected for a particular subset of this disease for a study. And for probably 80% of the group of patients in this disease, IL-1 or IL-6 are relevant biologic drivers of the disease. But for 20% or perhaps more, IL-1 and IL-6 don't seem to be the predominant biologic drivers of the disease. And so I think if we can establish a rationale for why other treatments such as or IL-18 blockers would make sense for a subset of patients, then the trial should be focused on those patients. As Nikolay said, you pick out subsets of patients that seem to be appropriate for a particular study. So I think using a broad classification or diagnostic criteria for this disease across the age range is appropriate, and then you focus trials on those patients who fit the biology of whatever the new treatment is.
Fabrizio, do you want to add to that at all?
I just want to add that and I thank Nikolay for being here and for providing his opinion. What he was talking about was the trial for SJIA, or Still's disease, children and adults together. What we will discuss in the future 2 days is also refractory. The one Dan was alluding to, the patient who failed IL-1 and IL-6, which is a completely different setting, okay? And for which the present ILAR diagnostic criteria may not be ideal. And therefore these do require some new thinking in terms of biomarker. Dan alluded to it, in terms of inclusion and exclusion, so that we can properly evaluate the efficacy in a very rare, because this is a rare population, in which it would be impossible to do controlled trials, essentially impossible to do controlled trials, with very specific and severe manifestations. And I think this is a topic, a strong topic for the day today and tomorrow.
So I have one question. I have one question. If you're specifically targeting the more refractory population, whichever way you define it, it could be patients who have already failed IL-1 and IL-6 inhibitors, and say a new intervention works for the more refractory patients. Do you think that this intervention would also work for the less refractory, or sort of the all-comers? In other words, should clinical studies be limited to the refractory population for new drugs, or should, the population still include the broader SJIA patients?
Nikolay, if I may answer, I jump in. If I may, it's going to be a problem of numerosity. Ideally, okay, we are looking to at least 2 or 3 different potential mechanisms of actions, and it's going to be difficult to recruit into large study for all comers at the same time, all these patients. The 2 IL-1 and IL-6 inhibitors trials that were done at the end of between 2008 and 2011 were possible because there were a huge number of refractory to glucocorticoids and whatever was available at that time, patients available in all centers to be treated. Now it's a different story. The great majority of the patients have easy access to IL-1 or IL-6 inhibitors. They're known to be efficacious. It's going to be a feasibility issue, the way I see it, because you can't do 3 trials on all comer, 200 patients each. This cannot be done. I think so. I don't know. Dan may have a different idea, but
Yuki, did you have? I see you're unmuted. Did you have a comment you wanted to make?
Not specifically at the moment.
Okay, sorry. Bas, I think your approach that you've pioneered in the Netherlands has really been a lumping approach. You've been very inclusive initially, and that we've learned an enormous amount from your work. So where do you see the subsets falling out of your group, that 20%, 30%, 40% that doesn't necessarily respond as beautifully as the rest? Could those be the basis of a kind of a trial like Randy Cron proposes in the chat, which is sort of an adaptive trial design, if I don't caricature the answer too badly, where you may try one thing and then another thing, and we study those interventions in sort of a series of N of 1 trials?
Yes, I very much like that idea. So I think what we have learned in the Netherlands is that really most patients with systemic JIA or Still's disease, or whatever you like to call, do have a favorable initial response to IL-1 blockade. And this is really more than 90% of the patients, but not all of the patients sustain their response. So I really believe in that window of opportunity that of course you develop. And for these patients, it would be very useful that we develop kind of a framework in which we test other hypotheses and also other pathways by blocking with blocking agents, of course. And I think one of the biggest problems is for doing such trials, except for the rarity of the patients, because these patients are rarer than SJIA in general, of course, is also that these should not be excluded because you have loosened up the inclusion criteria or the classification criteria at the start of the diagnosis. That wouldn't make sense to my opinion.
I think we have had some connection issues there. At least it looks like you're frozen. But I think I heard most of that answer.
I hope okay.
So one could imagine a trial where we start all patients on standard early therapy, and then in those who fail, we come up with a set of sort of algorithmic approaches. You either go arm A or arm B, where we have a lot of equipoise, because we don't really know what the next step is after, say, failing IL-1 blockade at the start. Is the right next step IL-6 blockade? Is the right next step interferon gamma, IL-18, JAK inhibitor, something else? We could develop such a trial, and then one would hope that populations might fall out of that if we study them well enough. I hope that was something like Randy Cron's idea.
Well, I'm not sure if I think there already exists populations of patients that have failed these drugs. So I don't know. I mean, I'm not sure if we want to start with a fresh set of patients, who are relatively new onset and, do this kind of progression. I think that, maybe a better first step would be to identify patients who are already refractory and do a trial on those patients to begin with.
I think that makes lots of sense. I think there are going to be two different areas. One is the new onset patients, and one is the refractory patients, where we think that the refractory patients could potentially be just biologically different as a function of their treatment, as a function of the chronicity of the disease. So I think we need to wrap up here. I will thank the panelists very much for their help, also in help in developing the slides. We had a lot of email exchanges to get this all set. And Rashmi, I'll turn it over to you if there's anything last comments you wanted to make.
No, I think this is a great segue into the next session, which is really about defining refractory patients in a more specific manner using IL-18. And I will pass it on to Dan Lovell, who has kindly agreed to moderate our next session.